We have a big group here today. Thank you. We also have some of our new faculty hospitalists. I'm not going to go and introduce everyone, but we have Dr. Tracy Proverb-Singh and Dr. Lorianne Leslie from the Cancer Center who are going to be going over oncologic emergencies.
So hello all. I may have spoken with one or several of you at this point. I'm Dr. Proverb-Singh, one of the medical oncologists focused on GI malignancies. Oncologic emergencies are one of those things that are critical to medicine, and we all kind of were there because we do medical training first. And obviously there are way too many to go through all of them. So we're just going to do kind of some highlights of things that you will be seeing and can easily manage without the help of oncologists, because sometimes, you know, obviously we're dealing with other things. So it helps to go through it. And if you have any questions, please feel free to interrupt. Okay, so as I said, a ton of different types of oncologic emergencies. You can categorize them just based on how they present. If you think about, you know, all the things that we do, both the cancer, the treatment, and the organs that are involved, you can have metabolic disturbances, things like tumor lysis syndrome, which Dr. Leslie is going to go through, hypercalcemia, hyponatremia, SIDH, which will be a lecture unto itself, so we're leaving that alone. Hematologic issues like neutropenic fever, which Dr. Leslie is going to go through, and then hyperviscosity syndrome, DIC. There are a whole bunch of hematologic issues that can happen. Structural issues, cord compression, which I'll briefly go through, and then kind of more complicated things that take a little bit more time to go through, but leptomeningeal disease, SVC syndrome. Has anybody seen that? Very classic. Get swelling of the face, and usually a tumor is compressing the SVC. Cardiac tamponade and pleural effusions and hydronephrosis are all things that tumors can cause. And then treatment-related side effects, so things that chemo can do acutely that cause acute emergencies, as well as some of the immune-related toxicity. And I'll talk about that because a lot of the notes I see, it's July. We've kind of increased the amount of things that we do in terms of immunotherapy and some of the treatments. And when they come in, you know, I see people on immunotherapy that says they're getting chemo. And it's not chemo, and how they're treated isn't the same. So we'll go through some of that just to kind of do a brief interaction. So I'm going to leave it to Dr. Leslie, and then I'll be back. You can flip through.
All right. So yes, as Tracy mentioned, I'm Lori Leslie. I'm one of the lymphoma oncologists at the Cancer Center. So I'm going to focus on the, I guess, two that are probably more common in our hematologic malignancy patients. So the first, which everyone probably has already seen and you probably saw as of July 1st or 2nd if you just started, neutropenic fever. So what is it? It has a pretty strict definition actually. So it's a fever of 101 once or 100.4 for at least an hour sustained, obviously without Tylenol or any other intervention. And that's in the setting of neutropenia. So the definition of neutropenia is a neutrophil count of less than 1,000. Severe neutropenia is the ANC of less than 500 or expected to fall to that level within 48 hours, which is important in our patients on treatment, depending on where they are and where their expected nadir is. And then profound neutropenia is an ANC less than 100, and those patients are at pretty high risk of spontaneous infections, as are those with severe neutropenia. So very importantly, when patients come in with this, the temperature should be checked orally. I'm going to kind of go through and highlight a few things that are important for new patients, new interns and residents. We'll go through some algorithms that are important to know from like the internal medicine perspective. But please, please, this is a huge deal. Please have it checked orally. So I always educate patients, tympanic, the forehead kind of thermometers are not good, axillary, it will be falsely low. Importantly, do not ever check a rectal temperature on cancer patients. This is like the most important takeaway point for interns, residents, rotating through the ER, on the floors. Please, it's either low neutrophil count, increased risk of mucosal trauma. You can actually cause a neutropenic infection in these patients if you do a rectal thermometer. Also, a lot of them are thrombocytopenic as well, and you can cause significant bleeding. I've had patients bleed so bad they need transfusions just from having a rectal temperature. So please, that's like very important. Neutropenic fever. So why does this happen? It can be either due to the chemo itself or due to the patient's underlying immune system and malignancy. For example, chemotherapy does affect the mucosal barrier all the way throughout the GI tract, so they can have oral ulcers through the esophagus, gastritis, colitis, and that increases the chance of bacteria escaping. And then also the immune system, there's a decreased neutrophil count with many of our chemotherapies that happens in a cyclic way. And then also the neutrophil function is disrupted by many of our chemotherapies. And then many of the underlying malignancies, hematologic and otherwise, cause a weakened immune system to start. So in the case of things like multiple myeloma, chronic lymphocytic leukemia, there's either abnormal immune complex formation or problems with immune complex clearance, which can increase the risk of infections. Many patients either have had splenectomy or are functionally asplenic, which increases the risk of infection with encapsulated organisms, for example. And then many lymphoma patients have an underlying T-cell defect, even B-cell lymphomas, that makes them unable to process or fight viral infections or respond appropriately to bacterial infections. And this is just in hematologic malignancies, but the same is true for most of our solid tumor patients who have gone through treatment or are on treatment. Source most commonly is unidentified, but it can be either microbiologically identified, which is like a patient that comes in with bacteremia causing their neutropenic fever. You have the source, you have the organism, the sensitivities, and you know how to treat. Versus like clinically identified, a patient that comes in with a pneumonia or a cellulitis, you don't have the organism, but clinically you have evidence of where the infection could be. And then unknown, which is the most common situation, a culture negative, clinically uncertain, but patient is neutropenic with fever. Mortality, depending on what's going on, the risk of the patient can be as high as 20%. So this is a serious emergency. I always tell my patients, if you have a fever at 2 in the morning, we need to know at 2 in the morning, you come in immediately, it can't wait overnight. And you actually, the guidelines are you need to have antibiotics started within 60 minutes of presentation of the international guidelines for neutropenic fever. Risk of complications are different depending on the patient. So a high-risk patient is someone who is severely neutropenic for greater than 7 days, has organ dysfunction or comorbidities that are not controlled. Low risk is someone with the neutropenia lasting less than 7 days, no significant comorbidities, and normal kidney and liver function. And this is just basically a presentation. There's several different scoring systems. I honestly don't really use that much, and mostly because it's kind of, you could tell pretty easily just by doing your basic H&P how high risk the patient is in terms of how medically well they are overall. Other high risk things that I tend to consider is, does the patient live really far away? Do they have no support at home? Are you worried that if you send them home and they get worse, they won't come back? Those type of things all should be taken into consideration. And then depending on the risk of the patient, there's different kind of neutropenic fever syndromes that can happen. So you see a patient that comes in with neutropenic. If they remain febrile despite 5 days of antibiotics in the high-risk population, or despite 2 days of antibiotics in a low-risk population, that's a persistent neutropenic fever, and you need to broaden, reculture, maybe scan, think about other things that could be causing the fever that you're not covering with your empiric therapy, which we'll talk about in a moment. And then there's this recrudescent neutropenic fever syndrome in a patient that's defervesced after their initial antibiotic therapy, then develops basically a new fever while still neutropenic. And then you also need to think more broadly about what could be causing that fever. And usually at this point, we have the infectious disease service involved, and that can be a little more complicated. So what is the treatment? Part of the treatment is prevention. So in patients who have a high risk of developing neutropenic fever, which is the 20% or greater according to the ASCO and NCCN guidelines, those are typically treated with primary prophylaxis. So before the neutropenic fever happens, usually they get growth factor to boost the neutrophils and minimize the nadir. Those patients still get neutropenic, but just as if they're neutropenic for a shorter period of time. And then preventative antimicrobials, which can be antibiotic, antifungal, and antiviral. Secondary prophylaxis we use if someone had a neutropenic fever or an infectious episode. It's a little more targeted in terms of the antimicrobials and GCSF directed on kind of what happened before and what you think the risk of recurrent neutropenic fever is. And then importantly, empiric therapy is what you guys are probably most familiar with getting involved with, and that's when you cover broadly while you're awaiting results. Again, this needs to be started within 60 minutes of presentation. I think the ER is excellent at doing that, and even probably sometimes over-aggressive. And then a very, very important, again, internal medicine standpoint, if you're ever starting antibiotics or treatment on a neutropenic patient, please make sure the cultures are obtained first. And it's not okay just to order in the computer and then order the antibiotics. Like, it's something you need to call, speak with the nurse, and make sure they know that has to be drawn before antibiotics are given, because missing a culture positive neutropenic fever will really dramatically change the course for the patient. It's very important. That's something to go the extra step in terms of your workflow. So I tried to get most of the algorithms, which are all based on international guidelines, from Up to Date, because I figure that's a source most of you have access to. And then if you had questions, you'll probably have access to the slides or the video, and you can always pull that up quickly if you're on call overnight. But the initial management here, this is kind of the first part of the slide. So it includes some of the high risk and low risk features that we talked about on the side. And then here it just, is highlighting at the top that it's an emergency and antibiotics need to be started immediately. So if the patient's not at high risk, usually this happens in the ER. If we see the patient in the clinic, you want to say, is there any problem with oral antibiotics? Do you think they can absorb? Do you have someone to take care of them? Are they able to contact you with problems? Do they live close enough to an inpatient facility? And if all that's okay in a low-risk patient, actually double coverage with oral antibiotics with a period of observation for at least 4 hours after starting is appropriate for some patients. So not every single patient has to get admitted. On the heme malignancy side, almost all of our patients are high risk. They almost always get admitted. On the solid tumor side, this probably comes into play more frequently because many of those patients are actually not high risk for neutropenic fever. If the patient is at high risk, then yes, they must be admitted for empiric IV therapy. And then so once the patient is, there in neutropenic fever, do they have severe sepsis or septic shock type of symptoms? So a sick patient or any specifically apparent radiographic or otherwise sign of infection. So no, then you use empiric regimens. Usually here we start with cefepime. If a patient has any history or signs and symptoms to suggest abdominal infection, typically we start with Zosyn instead of cefepime. And then meropenem or imipenem can be used if they have a history of a extended beta-lactam producing gram-negative rod in prior cultures, or if there's any reason to suspect that. If the patient is ill, then typically we do give double coverage gram-negative here, so aminoglycoside, for example, fluoroquinolones. If any patient comes in neutropenic fever and sick, always get ID on board quickly, and the ER doesn't as commonly do this gram-negative double coverage unless they have kind of assistance from the ID team, but this is a very sick patient. I've seen patients I had one traumatic patient in his 40s at the last dose of curative anti-chemotherapy, felt he was fine, waited a few hours to come in and actually died because, despite double coverage, because they get so sick so quickly. So really, any hint of them being unwell, add the double coverage. And same thing goes with MRSA and vancomycin. Not everybody needs vancomycin, but if there's any suspicion that they might have MRSA, skin and soft tissue infection, line-related infection, or anything, typically they get covered until those things come back as negative. Any vancomycin-resistant organism suspected, linezolid or daptomycin is added, and C. diff, if it's suspected, oral vancomycin is typically added. And there's some adjustments to this based on the antibiogram of the specific institution, so our preference is to start with cefepime as of now. So why don't we give everybody really broad spectrum antibiotics with meropenem and vancomycin? Well, the addition of vancomycin actually has not been shown to reduce mortality, so directed use is recommended. That's where that guideline comes from. And antibiotic overuse is associated with resistant organisms, which can be life-threatening infections in immunocompetent patients. It really can be life-ending for immunocompromised patients, so it's very important to have antibiotic stewardship in this population. Risk of neutropenia also varies with cancer patient type. So if you're getting a cyclic chemotherapy, typically the lowest time of your cancer nadir is about a week after chemo. So if you saw someone who had an IV, even high-dose chemo with the lymphoma surface in the cancer center the day before, and then they come in with fever, their neutrophils were 10, the day before, they're unlikely to be neutropenic, and you would have time to, start things, but talk with the oncologist about the timing of when their risk is and what antibiotics you should use. Versus, small molecular therapy, targeted therapies, as Tracy was kind of talking about a little bit earlier, we have a whole explosion of new agents in oncology. Some of the oral pill chemos do have a significant risk of neutropenia, others don't. So when in doubt, we always say cover broadly, but these are things that you need to speak with the oncology team about and get some general familiarity as you see more and more patients. Immunotherapy checkpoint don't typically cause neutropenia, though they can. The febrile syndromes are very different, and Tracy's going to go over that in a little more detail later. And then hormonal therapy. So I've seen patients come into the ER on 10 years of tamoxifen for their ductal carcinoma and in situ that's not even a cancer and be treated on the neutropenic fever cancer patient protocol. So that's a patient that is very low risk of neutropenia, and we shouldn't be giving cefepime and vanc for their rhinovirus. So how are we doing? I just also mentioned this to a lot of the new trainees in the room. This was a project one of the residents did a year or two ago with our group that was presented as a poster at ASH in 2018, looking at antibiotic usage and outcomes in febrile neutropenic adults with hematologic malignancies. And we found that only 40% had a source, most commonly bacteremia. 45.8% of febrile non-neutropenic patients did get cefepime, and a lot of those were very low risk, like very unlikely to be neutropenic, so overuse of cefepime. And majority of febrile patients, whether or not they were neutropenic, did get vancomycin, whether or not they had a risk of MRSA infection, and only 2% had a MRSA isolated, even from a nasal swab or elsewhere. So we're probably overusing, and there's been some quality improvement projects ongoing to try to look at that. So in summary, consider the likelihood of neutropenia in your patient, of course with the help of the oncology team. There's a lot of new drugs it's hard to keep straight, but tamoxifen 10 years is very different than AML induction therapy. Consider risk of the patient in terms of low risk, high risk comorbidities and severity of presentation. You have to start within 60 minutes of arrival, international guidelines. And please, 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 do not ever check a rectal temperature, please. That's like the most important thing. All right, so moving on. Any questions about neutropenic fever? Yeah.
I actually had a patient yesterday. He came in with a neutropenic fever and found to have acute appendicitis.
Mm-hmm.
And so I just was wondering about like the coverage of antibiotics. He was hemodynamically stable. So obviously febrile. He finished chemo. Last dose was Friday. So I covered him with Zosyn because of and he was eligible obviously for surgery given his neutropenia and everything going on. So would you have covered him also with double coverage as well in this patient?
So it depends. What cancer, what prior treatments, and what treatment currently on. That's a very complicated patient. And all of those things would change the recommendation significantly. And actually some patients we do take to the OR in that situation, even neutropenia. If the risk-benefit of what's going on clinically favors going ahead and fixing the infectious source. I have had patients go to the OR pancytopenic to fix intestinal perforation or whatever it is. So it's so important to get the whole team involved immediately when you see patients like that.
Cancer patient comes in neutropenic, and if you're here for CHF prophylaxis,
So we do prophylaxis for certain patients depending on what regimen they're on. If they're here for something else and there's no added risk, you don't necessarily change that. But it would very much depend on the situation. If they spiked a fever, of course, that's different. But if they're here for an unrelated reason and happen to be in their nadir, that's okay. Anything else? Okay. And most of those, all of those algorithms, I think you can find on UpToDate or easy to find later. Okay. So we'll move on to tumor lysis syndrome. So it's a syndrome of laboratory with or without clinical findings that is an emergency. It can be due to initiation of any anti-cancer therapy, pills, IV chemotherapy, even dexamethasone in our lymphoma patients, for example. And it can also be spontaneous. Risk varies significantly by cancer type, bulk of disease, and the type of treatment that you're starting. So typically the Cairo-Bishop definition is used for laboratory and clinical tumor lysis. Again, I've added this here, and closely monitoring and intervening on the clinical tumor lysis helps, of the laboratory tumor lysis helps prevent clinical tumor lysis. So pacified by having an elevated uric acid, elevated potassium, elevated phosphorus, and a low calcium. And the hypocalcemia is secondary to hyperphosphatemia and the calcium phosphate crystal deposition. The clinical tumor lysis syndrome can be renal failure, cardiac arrhythmia, and seizure. And actually, if you look at some guidelines, death is included as clinical tumor lysis. You never obviously want to see that as one of your clinical manifestations of tumor lysis. So low up to severe renal failure can occur. Cardiac arrhythmias, no intervention, non-urgent, symptomatic, life-threatening. And this grading 0 to 5 is typically what we use for clinical trials, for example. Manifestations. So patients will have typically first laboratory abnormalities. Some patients do present with a febrile type of illness, especially in our hematologic malignancy patients, but elevated potassium, The lysine tumor cells release nucleic acids that are processed, cause hyperuricemia. This uric acid is then precipitates in the renal tubules and causes also vasoconstriction, leading to acute kidney injury. The elevated phosphate binds with calcium. Deposition of the calcium phosphate in renal tubules also causes acute kidney injury. And then acute kidney injury worsens the hyperkalemia, worsens the hyperphosphatemia. So it's a really cyclic process. Just of note, I mentioned that spontaneous tumor lysis, it's slightly different. Hyperuricemia is there, but you typically don't see the same degree of hyperphosphatemia. Some of that might be just because it's due to rapid cell turnover, more so than the rapid lysis from treatment. So the thought is that the phosphate is used to make the new cells, and you don't see that same degree of hyperphosphatemia. It's kind of a minor detail. Doesn't really make that much difference clinically. So most of the treatment for tumor lysis is prevention of the clinical tumor lysis. So we'll go through algorithms in a moment just to talk about the risk, but IV fluid is key. These patients need to be very well hydrated once it's identified, and then also to prevent tumor lysis in higher risk patients. We have some medications we can use. Allopurinol, actually I think I have there we go. So allopurinol, here's the uric acid pathway, starting with purine catabolism, hypoxanthine, xanthine, uric acid, and allotonin with different degrees of solubility in the blood and urine. So allopurinol blocks at this stage here, the xanthine oxidase, and prevents uric acid from being created, but it doesn't do anything to the uric acid that's already there. So it doesn't dissolve the uric acid versus respiricase, which is an exogenous uric oxidase, and that does dissolve the uric acid usually in a matter of a few hours. So if you check blood work 4 or so hours after it's given, usually uric acid goes down to 0. Some patients need to be redosed if it's only reduced minimally and there's still aggressive tumor lysis going on. Some pros of allopurinol, especially for patients in the hospital. It's oral, it's cheap, it can be given IV, but the IV is very expensive. But it can lead to buildup of xanthine in these patients, which can be associated with a nephropathy. So it's not really preferred in high-risk patients. Versus respiricase, it's very expensive, but it is immediate. It is contraindicated in G6PD deficiency. So it's one of the drugs to think about for your boards, or if you see a patient from an appropriate area, it causes that hemoglobinemia and a hemolytic crisis in a few patients. So something to keep in mind. This is a busy slide, but again, accessible and up to date if you're seeing a patient and want to look up their risk of tumor lysis. But just to highlight a few things, low risk, most solid tumors fall in the low risk category, or some hematologic malignancies that are either low grade, like the indolent slow growing B-cell non-Hodgkin lymphomas with a normal LDH, and CLL that has a low tumor bulk. Intermediate risk, kind of many of the hematologic malignancies that have normal LDH. LDH is kind of a marker in lymphomas, for example, of cell turnover. Even Burkitt lymphoma, which is the fastest growing lymphoma known, as long as the LDH is less than 2 times the upper limit of normal, that's considered an intermediate risk patient. And then high risk are patients with bulky disease or elevated LDH, ALL, things like that, or any intermediate risk patient that otherwise has renal dysfunction or abnormal labs at baseline. Those are considered high risk. And just for an example here, even for CLL, a pill, venetoclax, when we first started that protocol, starting at the max dose, 3 patients died from tumor lysis because you don't think you take a pill and the cells die so quickly, a patient's going to have tumor lysis. So now you'll see patients admitted to the hospital for ramp up of an oral pill because the risk of TLS is so high, it has to be done in the hospital. So how do we prophylax these patients? This is another kind of algorithm to go through with your specific patient that I think is helpful. You look at their laboratory tests and estimate the tumor burden. If it's minimal risk, patients can just kind of be observed, no prophylaxis. For intermediate risk, usually hydration, and you can choose either allopurinol or respiricase. And importantly, especially for the internal medicine people in the room, labs are frequent every 8 to 12 hours in these patients. And high-risk patients, prophylaxis, you skip the allopurinol. It doesn't do anything about the uric acid that's already formed. You jump straight to respiricase. These patients should be on a cardiac monitor, telemetry, due to the electrolyte disturbance problem. And labs are more frequent, every 6 to 8 hours. And then in clinical TLS, so if patients have actually the clinical syndrome, hydration, respiricase, these patients should be in the ICU. And lab monitoring is every 4 hours, which is kind of sometimes even hard to get that done logistically outside of the ICU. So important, mostly due to initiation of treatment, but can be spontaneous. There's characteristic electrolyte disturbances that are slightly different between spontaneous and treatment-related. Prevention is key, and preserving kidneys is key. So it's all about hydration and making sure that you can process the electrolyte and clear electrolyte abnormalities, and then very frequent monitoring, as frequent as every 4 hours is required. And that's it.
And we'll have
Any questions about hemolysis?
Yeah.
Yeah.
Besides the calcium, the potassium, any other labs that we should be doing as well?
Uric acid, LDH typically we monitor as a marker too if it's a hematologic malignancy. Especially the electrolytes and the uric acid is very important.
the next two I'm going to go through pretty quickly because it's mainly just something to identify and be able to treat quickly before the other services kind of help you out. And the last one being what I wanted to focus on a little bit more time because these are the newer drugs. So for hypercalcemia, I'm sure everybody at this point has seen hypercalcemia malignancy, frequently found in a lot of the solid tumors and multiple myeloma, associated often with a very poor prognosis as well as stage 4 disease. PTH is usually the regulator of calcium in the body. It's usually PTH mediated, but the fact is it's often extrinsic due to the tumor producing a PTH related protein. Much like the tumor lysis, kind of in the opposite way, it involves the calcium and phosphorus pairing. And osteoclasts increase the amount of calcium that's in the body and then decreases the amount of phosphorus. So you'll see the opposite of what you see for tumor lysis. During this process with PTH regulating both the osteoclast, it also regulates the kidney function to increase absorption of the calcium and decrease the renal excretion of phosphorus, and then also involves intestinal absorption. So it involves every aspect. So once you end up with this abnormal PTH, it's just a cascade of all the different areas in which calcium and phosphorus mechanisms are involved. So you just see the calcium rising and rising. There's also kind of a local tumor effect where you can have calcium rise just because cytokines are released, and it directly influences the osteoclast in terms of bone resorption. And this happens often in metastatic disease with extensive bony mets. And this involves the rank ligand. That's all in the osteoclast and how bone is made. So about 80% is related to the PTHRP, the rest of it being just intrinsic and then vitamin D metabolism. That's a lot less frequent in cancer. The clinical presentation, if you see, usually you have an elderly patient with a solid tumor, they have a progressive altered mental status, they have potential coma, weakness, anorexia, signs of dehydration with thirst and decreased urine output, constipation, nausea, vomiting. This is your classic patient. Mild hypercalcemia, a little under 12, moderate, and then severe being above 14. Remember that these patients have to be checked for their albumin state, especially solid tumor patients often have low nutritional state when they're stage 4 and when they're at this stage. So make sure that you adjust for their albumin level in order to get their true calcium. You can also do an ionized calcium, which will give you the same thing. Kind of additional labs that you check aside from just the calcium or your PTH, PTHRP, they take a while to come back, so they're not going to be involved in your treatment decisions. Treatment, sorry, this is much smaller than I thought it was going to be. But the first and foremost is always aggressive hydration. These patients are usually, multiple liters down in terms of their hydration. So at least 2 liters bolus and then aggressive hydration. This is something that often doesn't get, done. You get the initial couple of liters and you need to really maintain them for the next 2 to 3 days to keep them adequately hydrated and get them to euvolemia. You look at their other labs and a lot of it will have to do with what their other functionality is, but often it's just normal saline. You want a isotonic solution. You're looking at your calcium. So in patients with heart failure, obviously this amount of hydration is sometimes troublesome. Lasix will bring down your calcium level, but it'll also dehydrate them. So you have to kind of use that with balance. Make sure you get a couple of liters in before you start using Lasix. It also transiently brings down the calcium, but you have the contra. So if you need it because of their volume status, then you can use it, but often you really do need to be cautious with Lasix. It's used in an emergency. Calcitonin will help you bring that level down, but tachyphylaxis and other things, you don't want to maintain that. That's just an acute drop if the level's too high. And if the patient is kind of in coma or the mental status is the biggest issue. Steroids do work for some of these cancer patients. They can be used, sparingly. It kind of complements all the other things that you're doing. The mainstay of treatment is bisphosphonates. This needs to be put in early. So often, patients will come through the ER. The ER is not always the one that's going to be putting the bisphosphonate. They need to get a couple of liters in because these drugs can be nephrotoxic and have to be dosed accordingly. So the biggest thing is to get the fluids in and then to make sure they get their treatment for the hypercalcemia so the number actually comes down. It takes anywhere from 2 to 4 days for that to improve. So you're not going to see the effects of it, but it needs to get in. And always when you're acquiring a patient, just make sure the ER hasn't done it so you don't double up the dosing. Because sometimes patients will get, the bisphosphonate in the ER and sometimes they won't. This works by direct mechanism of kind of reversing all the things that we talked about, inducing the osteoclast apoptosis and other mechanisms to reduce the amount of calcium and kind of stopping that cyclical cycle. Newer drugs are these rank ligand inhibitors. We use them frequently in patients with metastatic disease with bony disease as a preventative measure to help reduce the risk of seeing hypercalcemia and also improving the outcomes of patients with bony mets. What it does, denosumab is the main one we use. This you usually won't be doing in the hospital. It's too expensive. We often do it outpatient, but there is some newer data that's saying that it may work really well for patients that are bisphosphonate refractory. So in certain circumstances where you've already done aggressive hydration, calcitonin, bisphosphonate, and you're 5 days out and the calcium is not budging, you've tried steroids, at this point, then you can consider talking to the pharmacy about trying to get another agent to help bring that calcium down.
Question.
Yep, of course.
Does the notion have same risk
Of what?
the
Osteonecrosis of the jaw. Yeah, so in long term, technically speaking, yes, but in the number of cases are far fewer. So bisphosphonates have a much higher risk of it. You can still get the risk with the rank ligand inhibitors, but it's just not as frequent. And it's more for long-term use, not single use.
A patient who has hypercalcemia and AKI, what do you do? Because I had the same case and we gave hydration, but obviously he's elderly and we didn't want to also make him fluid overloaded, and we did calcitonin, but we didn't use bisphosphonate, so I guess in that case they're contraindicated.
It depends how severe the renal dysfunction is, and it depends on the etiology of the renal dysfunction. So in patients where the renal dysfunction is due to aggressive, either dehydration or due to in part the hypercalcemia. Yeah, and it depends. Sometimes you get a little bit of improvement, and then you have to do the GFR in older patients because the computer calculates it, but you have to actually see what it is. There is a renal dose for bisphosphonates that can be given safely, and often we do recommend that, especially in the setting of elevated calcium. So everything is going to have to be, with your consultants and with everybody, but you're looking at renal function in the context of the entire patient and what's going to be the most dangerous to them.
And the PTRH came back, it was like 2.7, a little bit elevated, I guess, in the setting. He
Did they
also
have
has lung
bony
cancer.
mats?
Lung cancer, yeah.
Did he have bone mats or?
That I don't remember.
Okay. Because as I said, 80% of the time it is from the PTH related protein, but then there's still 20% of the time that it can come from direct tumor involvement on the osteoclasts themselves, and this is where steroids may be beneficial because you can reduce the effects of cytokines from the tumor and somewhat decrease some of that, but it's not going to be usually enough. Usually you do need the bisphosphonate at some point, and it does depend on if they have bony mets. So there are, a lot of these cancer patients, especially the solid tumor patients, you're not working in isolation of any one particular problem. You're often having to balance several of their chronic disease, their acute problem, plus the cancer and what the cancer has caused. Sometimes the cancer causes things like structural changes that can influence either kidney function or other things. So everything is taken big picture, and then you're looking at each individual problem. So, and there is a renal dose for it. Any other? I saw a hand.
Yeah. Any steroid that is studied that is more effective, dexamethasone versus lamotrigine versus pred?
No, the studies that I looked at usually use prednisone or dexamethasone, but not in particular. It's kind of the class of drugs. Okay, and so spinal cord compression, the only reason we bring this up is kind of the idea of structural component, and this is kind of the most dangerous out of all of the ones that we encounter, and the things that the ER encounters, right away, and the use of steroids in this situation. So we know that any of these solid tumors can cause structural damage, any bone mets in the spine that can cause dural involvement and compress the spinal cord. These aren't always your patients that have weakness or the classic symptoms of urinary incontinence, kind of sensory changes. These could be people that are walking in saying, oh, I feel a little bit weak, I have pain. These are the ones that you may find early in their course, and these are the ones to intervene upon. Regardless of what their metastatic disease is, it's important to kind of evaluate that patient. If they have point-specific back pain, worse when they're lying down, tender to palpation, and known bony mets, even if they don't, you do imaging, say a plain film and you see bony mets, MRI is the gold standard to find out if there is epidural involvement. If there's epidural involvement, you get steroids involved right away, because if you can reverse these symptoms before they have them, you can often prevent patients from having long-term effects. So anybody who walks in usually can be salvaged. You call neurosurgery right away, have steroids on board, and then radiation, and often these patients can preserve their level of functioning, which is critical for all these stage 4 patients. I guess the only other thing is that you get 10 of dex in, that's the standard, and then 4 Q6 to make sure you have the continuing dose until neurosurgical evaluation or initiation of radiation. Often people can have permanent damage if they already have a lot of the paraplegic symptoms. So the most kind of important, how many people are familiar with any of the immune drugs at this point? Are any of those, so the chemotherapies, these are kind of standard, you can look it up, like things like methotrexate can cause acute kidney injury, and it should be recognized that if people get high dose methotrexate, you should know that. Ifosfamide can get confusion, but usually these are all inpatient things. All the new drugs can cause any sort of organ failure, alter mental status, any other things that are acute emergencies, and it's important to kind of go through what medications they're on, as Dr. Lezick mentioned, and really talk to the oncologist about what these drugs can and cannot do, because sometimes, a lot of the newer therapies can have a lot of atypical side effects. But the immunotherapies, kind of, I guess, nivolumab is Yervoy, pembrolizumab is Keytruda. You may have heard them, seen them on commercials. Ipilimumab is, no, that's Yervoy. Opdivo is the first one. I know all the generics still left over from fellowship. Atezolizumab, like these are all drugs that are not chemo. So these are immune therapies. And familiarity, no familiarity?
Patients on them, but I don't know them that well.
But even when you're talking to the oncology team, having the specific name is so much more helpful than even having the day they got the dose. Just saying patient on chemo can mean literally.
Well, I say immunotherapy and then the
or you can
medication.
say, whatever the medication is.
Exactly.
Very helpful.
And so these are the ones that are FDA approved. And so that's why I listed them here, because they're FDA approved for various solid and liquid tumors. The CAR T cells are inherently just for our liquid tumor patients. And it'd be really critical to know if they're on that. Usually a patient will tell you if they come into the ER and they're on that. And then we have a slew of phase 1 clinical trials, which have a whole slew of immune therapies that are, newer and have just letters and numbers. It's important that we know what the trial is if you're seeing that patient. Exactly. Yes.
Just quickly look it up what it is.
And if you tell the oncologist, then often we can help guide you through what things need to be ordered and tested. So immunotherapy, just in brief, and I'm sure at this point, I'm hoping that you guys have heard a little bit about it, but it's about the T cell activation. And we know that T cells are activated by multiple signals. We know when you have a dendritic cell, an antigen presenting cell, does this sound familiar to everybody? Yeah. Antigen presenting cell on their MHC molecule presenting an antigen to a T cell. This is reminding of med school. A T cell receptor from your cytotoxic or your CD a T cell will match that, and you have your first signal. That's the activation signal. You need a second complementary signal, which is the CD28 pairing with the B7, and that says, yes, activate this T cell, proliferate, divide, and go find the antigen that we just presented and kill it. There is also inhibitory signals, because obviously you don't want T cells just to be activated wildly. So our body has natural mechanisms with which to control that activation process. So there are several inhibitory signals. And a lot of the new checkpoint inhibitors, is the other fancy name for immunotherapy, is used on this basis. The fact that we have regulatory inhibitory signals for our T cell activation. One of the natural ones is CTLA4 and PD-L1. As a T cell is proliferates, and is seeing an antigen, once you're starting that cascade of response, PD-L1 and CTLA4 are upregulated on the T cells in order to say slow down this immune response, and they get competing signals. So they respond to the same signal, so the B7, to help tamper that response. The way immunotherapy works is it blocks the PD-L1 signaling in order to keep the T cell activated. Does that make sense? It's a negative of a negative. So the negative inhibitory signal is what is actually blocked with these newer immunotherapies. So it allows a T cell to keep being active. The tumor, and when we're thinking of tumor biology, mimics some of the natural regulatory systems that we have with our natural T cells and how we regulate our immune system. What it does is it cloaks itself sometimes in PD-L1 in order to hide or evade from the immune system. And that's one way that it can force the T cells to become inactive. And so that's one of the mechanisms for a lot of these drugs. So it blocks the T cell, or the CTLA4 and PD-L1 on the T cells, but it also can block it on the tumor in order to allow for the T cells to stay active and go after the tumor. So that's the general mechanism, very brief and very simplistic, about how these new checkpoint inhibitors work. They're not the only ones, and the reason I mentioned clinical trial is in kind of those first three, you can see CTLA4, PD-L1, and PD-1. Those are the signals that have all the approved drugs. So everything that I talked about are in that pathway, in that group of checkpoints that we know about. These are just a small smattering of the signals that we're looking at in clinical trials and looking at for other agents, and they involve immune response and have similar side effect profile. So you'll see, I circled the other ones that we have clinical trials ongoing right now. So if you see anything that says GITR or LAG3, know it's an immune drug, it's a clinical trial, and that's important for the oncologist to know about. So had anybody heard of the itises? So immunotherapy basically causes inflammation of any part of the body. There's some that are more common, more severe, but then they're less common, but also need to be recognized. So kind of from head to toe, anywhere you can get inflammation. The most common are dermatitis, pruritus, obviously not super dangerous, but can be if left unattended. So colitis is another one that we can see in the early trials. A lot of patients with with grade 4 colitis had more increased mortality and morbidity when they weren't recognized as being immune related. So you can guess what's colitis. What side effect would you have somebody presenting with? Diarrhea, pretty severe diarrhea. So patient on immunotherapy with diarrhea, you always check for immune related toxicity. So in any of these patients, the things that are the most dangerous are the myocarditis, endocarditis. If we don't recognize it, the prevalence is anywhere between 1% for each of them, so about 3% overall. It's actually somewhat underreported. What you start seeing is troponin elevation, CK elevation, without any ST changes on the EKG. You may see prolongation of the different intervals on the EKG. You may see skip beats. It's due to the T cells infiltrating the myocardium. So it's a very different mechanism, and it's incredibly deadly. So if you see a patient that doesn't have typical cardiac symptoms, or it doesn't look like a typical MI, but they have all their enzymes up without chest pain and without anything else, and they're on immunotherapy, and their EKG isn't normal, then it's definitely a situation where the cardiologist needs to be involved. They have to be monitored, and the mortality is almost 100% if not recognized. And they require, aggressive therapy. So we'll go, yeah, so the management, I mean, you guys can look at this and see all the different areas where you can see symptoms for so basically early identification, understanding that the patient is on immunotherapy rather than chemotherapy is the first step in early identification. Rule out other etiologies pretty quickly. So if they're coming in with diarrhea, make sure we're checking the stool for C. diff, for other GI pathogens, and then think of the timeline. On average, usually colitis can happen within the first 7 weeks of therapy, but they tend to be a little bit more delayed compared to chemotherapy in terms of side effects. The severity is also critically important. A lot of these patients are managed outpatient, so you won't see them. They're managed with oral steroids and often never get to the point of needing the hospital. However, in patients that do require the hospital, it means their symptoms are refractory to either what they were doing or they weren't identified early enough and need systemic steroids, usually intravenous. Usually we start with methylprednisolone 1 to 2 milligrams per kilogram per day, intravenous or equivalent. Usually we stick to this. This needs to be done quickly. It's usually in 2 separate doses in order to help reduce the symptoms. We use the other immunomodulators, but again, oncology would be involved at that point if they're refractory to that. So in any patients that continue to have symptoms despite having steroids for 3 days, or the symptoms haven't abated completely or haven't gone back to at least mild, then we're looking at other immunosuppressants, so TNF alpha inhibitors, and different immunosuppressions that we use for like transplant patients. And identifying these symptoms early, ruling out other causes is critically important in their management. I think that is it. So I'll put this one back up because I think, any questions about the immune drugs or the side effects? So for myocarditis specifically is a little bit trickier. So anytime we have these symptoms, if we're concerned for myocarditis, you want to make sure they're on telemetry. You want to make sure that cardiology is involved and oncology is involved right away. You're trending their troponins as you would normally do, and you're watching their EKG changes. You still give the 1 mg per kg for the methylprednisolone. Often we actually do 2 mg, so you can do 1 to 2. You do the highest dose of steroids, and often simultaneously we'll actually put on any of the immunosuppressants like Cellcept or we don't use infliximab for it, but Cellcept or Tacro, but it's usually Cellcept that we use. If they fail to respond within a day, then often we're looking at other treatments. So these are patients that may require ECMO, that may require other cardiac support, and they will decline rather quickly and declare themselves. We've actually had to give people chemotherapy, so Cytoxin, to get rid of the immune response. MRI will help us identify, a cardiac MRI will help you identify thickening of the myocardium. You can get an echo to make sure that there's no specific lateral wall motion abnormality. It's usually a global and a thickening of the myocardium because the T cells have infiltrated. So you're seeing very different symptoms and very different, it looks almost like a restrictive cardiomyopathy in the setting of what looks to be a massive MI. And if it doesn't look consistent with any of those things, it's probably the immunotherapy, and we usually need to act. We've had to give, there are now case reports of people getting chemotherapy with trying to suppress the immune response. Most patients do succumb to this side effect, so it's important to recognize it early.
The immunotherapy, I find that a lot of patients are on it and then they come into the hospital. It's not necessarily related to the cancer, but I always, I'm not familiar with these medications. So aside from these things that we have to be mindful of, we also sometimes, we don't even carry the medications. And if the patient misses doses, what are the side effects or the things that we should watch out for?
So they're actually studying the administration of these medications, because it is, like, if you looked at the mechanism, you're affecting the T cells in the innate immune system. And so giving the drug at a sequential dose was how it was studied initially because of how chemotherapy trials were done. And now we're looking at, do patients actually need that sequence of events? Do they need to be treated every 2 weeks? So we don't provide the drug inpatient when they miss a dose. They deal with whatever their acute medical issue is first. If it's unrelated to the immunotherapy, then they just come in and get their treatment when they're back in the office. If it's related to the immunotherapy, then they need to be treated adequately for it, get back to a grade 1, and then wean off steroids in order to be able to retry for their next dose. I think we're fine for time now. Okay. Anything else for that?
Thanks, guys.
Really helpful, thank you.
Of course, you have a lot.
And that's how we do it.
Huh?
There's
That's
still
not,
a few other stuff.
yeah.
Thank you.
Yeah.